Welcome to the 6th Annual Health Disparities Conference here at Teachers College, Clem University. I am delighted to welcome you. I am Dr. Barbara Wallace, and so we're going to get right into our program. And as you know, we are determined to be the best on-time conference ever. So we're going to start with our cultural opening, which this year is rather brief, but quite powerful, and that's going to involve Nana Karantama Ayabuafo L, the Akumfo Hini, head of all Akumfo in North America, King Shaman, and president of the Asuna Abreddy Shrine in Philadelphia, providing us with a cultural experience. Thank you very much. Oh, asasi jinsanum, oduma kuma tredi ampon. Nana me frau jinsanum. Nano paribi a konfo akoma hene. Wona wudom jinsanum ya hinwa. Enye de adade kofi jinsanum. Misreba kwa na masrebu nyina. Nana esi korbi ensa. Ntakrabo ntakrodoso jinsanum. Na fetu nene akunedi abana se me freno and opay jin sanum. Oh, tigre bofo said mohiniba wonsu be jin sanum. Nananum me freba akwana ma frebu nyina anye boni ampa se ene fida enipa bebre bai sana nana ohima oparibia jiriwato simienu ose Bra, yebeye, the 6th Annual Health Disparities Conference at Teachers College. Misre wunyina ti asem betumi boao. Ubeye hodin enemunyem ohodie wadauruma yebeye nkwanso se nipa eba no obe hwehwe kwanso se obeye biakuye asem no na wobefa na asem nyina akabon to be boabwa nipa woriasi wo baby ya. Nana me freba kwa ma fremu nyina. Se wona wudom wonyina boabwa yo. Adarma. Abara Gani. Good morning, everyone. Alafia to all of you. Assalamu alaikum and so. I'm very happy to be a part of the 6th Annual Health Disparities Conference. I would just like to translate my libation for you. First, I called on the supreme creative spirit of all the world to come and acknowledge everyone who is gathered today. Also, I acknowledge the Earth Mother who provides sustenance for our beings. I called on some of the ancient ancestors by name to come and witness this gathering that is being made possible by the catalyst. First, Nana Ohimai Jiriwa II, you know her as Dr. Barbara Wallace, and all of the volunteers, the provost, and the other members of Teachers College who have opened the doors for us. I ask that each and every person who comes can be furthered and benefited by what you hear and by what you see today. I ask that you all have long life, good health, and that you're strong in your work to help the peoples around the world, wherever they may be, so that we do in fact have a century of health equity for everyone. I ask that as you move around today, that you meet new people and make new relationships that are long-lasting to benefit not only you and your families and your communities, but everyone else that you served. I ask that there be prosperity in your lives and harmony so that when you reach home, you can take the joy and the learning from this conference as a stepping stone in your success. I ask that all the students that are here not only gain credits, but gain insights as to how they can participate and add to this century of health equity for all. I asked also that CHEUSE be able to continue its work and that more young people can join the gathering so that they too can participate in this exciting event that has a great impact upon everyone around the world. And now I would like to invite all of you to just join me in taking a moment of silence to express gratitude for a mentor in your life or an ancestor or a friend or a loved one who has supported you and who believes in your being here at the 6th Annual Health Disparities Conference, a mark to further you in your career. So could you all just close your eyes for a moment and let's have a moment of silence as our expression of gratitude. Thank you. Much peace, joy, and victory.
Wow, that was a powerful suggestion. I went all the way back to my first grade teacher and thanked her. And then I was on the tot lot with my grandmother, thanking her. And then I went to graduate school and even thanked my psychoanalytic professor who showed bias against me. So that was really quite an exercise. So I am absolutely delighted to have this opportunity to share with you all today. And of course, you're all going to get checks for $500 because you're the ones here on time. So today I'm going to address in this conference opening the conference theme, and that is urban and global health, culturally appropriate research, practice, and policy. And then we're going to have a special focus, at least in this address, on the year 2014, 30th year since the dawning of the crack cocaine epidemic in 1984. And toward that end, during our reception from 5:30 to 7:30, you'll have an opportunity to fondle this journal, which is a special theme issue of the Journal of Equity and Health, which is also an online open access journal. And because they turned out so nice, I can't sell them for $10. I've got to sell them for $20, especially since I had to pay extra for rush. But in any event, you'll get to see what is being offered through that special theme issue of the Journal of Equity and Health. So to get started, I guess I wanted to share something. Since I actually went back to graduate school and thanked some of my professors, actually several of them, like my dissertation sponsor was actually the first one who came to mind. I just wanted to share what was the inspiration for creating this conference. And that really involved being a graduate student at the City University of New York and hearing about this wonderful conference at Teachers College back in 1982 that had a focus on culture. And of course, because I was in a graduate program in psychology, even though that was quite a while ago, it's still true for many graduate students that when you are looking at your curriculum, you wonder, where is the focus on culture? And so all the graduate students were hungry to come to Teachers College for the annual Winter Roundtable on cross-cultural psychology and education, where my mentor came, where my mentors have been honored through that conference. So I said, that's the kind of experience I want to create, where those who are thirsty can come and drink of culture, of what is culturally appropriate. And since 1985, the focus has been on health disparities and more recently on health equity. So that's really why you're here. And so it remains true that beyond graduate school, as you're an early career professional, as you're an assistant, associate, full professor, as you are a director of healthcare, whatever it is that you do, as you are a school teacher, a nurse, it remains true that we continue to need quality, expert, continuing education that addresses our need to find out what is the latest cutting edge research and topics when it comes to issues of culture. And so again, the lens is health equity and health disparities. So what you see in this particular image here is really a synthesis and integration of the state of the art when it comes to urban and global health from the perspective of crack cocaine. Because it turns out that there is actually a serious public health crisis that is still occurring in our global community. If you look at the literature, there is a wealth of research coming out of Brazil, where there is a serious crack cocaine epidemic, as well as places like Canada. You'll find articles from Australia, from Turkey, from South America. We're talking 2011, 2012, 2013 articles. So this is really an ongoing public health crisis that merely dawned in 1984. So at the bottom, you see the 1984 dawning, the 1985 to 1986 eruption and media explosion of the crack cocaine epidemic. And then you see that there's a nexus of 7 factors. 1, a public health crisis. 2, flawed and unjust war on drugs policy. 3, a crisis of mass incarceration. 4, a crisis of trust in governing infrastructure. 5, a crisis of disruption in social progress. 6, a crisis of special vulnerable populations. And then voila, what do we have finally? All of this drives and has been driving since the onset of the epidemic innovation and evolution in research, treatment, service delivery models of practice, training, outreach, advocacy, and policy. So as much as there has been pain and suffering, there has also been innovation and evolution. And of course, if you think about the HIV/AIDS epidemic, then you know that that's been the case in that area, at least for some populations who've benefited more than others. Okay, so this is the symbol of the Journal of Equity and Health, which is also the symbol of the Research Group on Disparities in Health. So the journal is actually an initiative of the Research Group on Disparities in Health. And thanks to the provost here at Teachers College, something called the Center for Health Equity and Urban Science Education was approved as a new center. It was launched around this time, 1 year ago, with Professor Christopher Enden and I standing at this podium at 10:45 on March 14th. And so the Research Group on Disparities in Health now has a new home within CHEUSE, the Center for Health Equity and Urban Science Education. So there are 12 articles in this particular special theme issue. The first is the introduction, and here we basically get an overview in terms of the perspectives that are going to be provided, whether from anthropology, sociology, psychiatry, et cetera. And then we're going to go to a chronology of crack and the nexus of 7 repercussions in the second article. And so just to elaborate, what is the nature of this public health crisis? Well, first of all, it's of considerable magnitude. It's urban, it's global. It's been of long duration, 30 years and counting. It involves overlapping epidemics of crack, other drug use. Right now, we're starting to see what may be our second heroin epidemic, or concerns that are in the media about heroin, whereas in the 1990s, there was an overlapping epidemic with heroin as well then. Of course, an upsurge in the use of marijuana, the HIV/AIDS epidemic, and the violence epidemic, as well as related disease syndemics. This flawed and unjust war on drugs policy, I won't go into all of the details, but imagine that an athlete in Boston ends up having a cocaine overdose, a powder cocaine overdose, and it's approximately 1 month before a November election. And politicians collude and take advantage of that to basically rush through legislation within just 30 days, not the normal process, a process that resulted in the 1986 Anti-Drug Abuse Act, or shall I say the Anti-Drug Abuse Act of 1986. It turned out that some of the testimony that was provided, an individual who didn't even have the Ph.D. that they claimed to have, had suggested to Congress that crack was basically so dangerous that it kind of led to the decision that there should be a 500-to-1 ratio. In other words, if I am in possession of powder cocaine, well, I would have to have 500 times the amount of crack to trigger the same mandatory minimum sentence. And then in 1988, there was the Anti-Drug Abuse Act of 1988 that led to mandatory minimum sentences for first-time offenders as well. So the idea is that until Obama signed legislation in August of 2010, and it basically led to the Fair Sentencing Act going into effect on November 1st, 2011, we were basically facing that very harsh disparity. And so we call this flawed and unjust war on drugs policy that has driven irrational responses to the public health crisis of overlapping epidemics. We have then, as a result of that legislation, mandatory minimum sentences that led to the United States becoming the global leader in rates of incarceration. Imagine that at the height of apartheid in South Africa, let's say 1994, the United States, if the crack cocaine epidemic was dawning in 1984, by 1994, we had surpassed South Africa's rate of incarceration, okay, of blacks. We had surpassed them here in the United States. And so this is a crisis where individuals are still incarcerated. Even though there is the Fair Sentencing Act, there are those who are waiting for justice. And so we've seen a burgeoning of the United States prison industrial complex that has been prolonged, enduring, and includes a host of national and international consequences. We also use the term collateral consequences, from breaking up families, breaking up partnerships, contributing to gentrification. When individuals are incarcerated, they lose their housing. You know, there was a time when we were working with clients and we heard that they were homeless in New York City. We'd be like, oh, we have to address homelessness right away. Now we're telling people, okay, so do you have an iron in your locker at the shelter? Can you just iron your clothes and go to work? I mean, that's how massive the homelessness crisis has become, that we can't even consider it a kind of urgent indicator of someone being in crisis. It's become normative. So those are some of the collateral consequences. Then a crisis of trust in the governing infrastructure of the United States. Not only the legislature that, as I just explained, in 1986 did some rather bizarre things in passing controversial legislation in just 30 days in time for the November elections, where they could be seen as tough on crime, tough on drugs, but also the judiciary, because the judiciary was forced to basically hand out mandatory minimum sentences. They could not exercise discretion. And New York State actually was a leader, because there's also not only the federal legislation, but New York State had the Rockefeller drug laws. When Rockefeller thought he was going to run for president, he enacted some of the harshest mandatory minimums in the United States. And so they were recently repealed. The criminal justice system, a crisis of trust in the criminal justice system overall, because of the lack of discretion, because of the clear disparity in sentencing between mostly African Americans and also Hispanics, who tended to be in possession of crack, versus those who might be in Nassau County, Westchester County, the suburbs of New Jersey, and might have a ton of powder cocaine. But they also weren't subjected to racial profiling, stop and frisk procedures. Many of you are aware of the controversial stop and frisk procedures that have led to record levels of African American and Latinos being stopped, frisked. Turns out in New York State, you might have marijuana on you. Okay, so you have it on you. But it becomes a criminal offense when you bring it out to the open air. So I, as a police officer, say to a young 17-year-old, open your backpack, empty your pockets. As soon as you agree to do that, you have broken the law now. But if you're just walking around with it, so you need to know that these stop and frisk procedures were initiated during the height of the crack cocaine epidemic as part of the war on drugs. And so the best way to read about all of this in an exciting manner, is it the Journal or is it Michelle Alexander's book, The New Jim Crow, 2010? And so law enforcement, the loss of trust in law enforcement, because the DEA basically trained police officers across the nation in how to do stop and frisk procedures, which now are being applied to adolescents, young adults, mostly males, in urban centers where they're looking for marijuana. And so law enforcement has also been a part of this, racial profiling, and it manifests in the national consciousness as a widespread mistrust and suspicion. Then there's a crisis of mass incarceration with the I went the wrong way. Okay, how do I keep going? Okay. Crisis of disruption in social progress and gains made since the civil rights movement that gave way to ongoing community mobilization efforts, as well as the societal-wide improvements in human relations, the overcoming of negative stereotypes about members of various racial, ethnic, religious groups. A crisis of special vulnerable populations. In other words, whether we're talking about those, the incarcerated population, they within themselves constitute a vulnerable population. You just can't decide you want to go to the Institutional Review Board and propose to do research with those who are incarcerated. No, they are a special vulnerable population, as are those who have comorbidity, such as not only chemical dependence, but also psychiatric disorders, post-traumatic stress disorder, bipolar disorder. You've heard that this week in the news. It is perhaps one of the most common combinations that we see today. Innovation and evolution, as I said earlier, in research, treatment, service delivery, models of practice, outreach, advocacy, and policy. If it wasn't for the Sentencing Project, if it wasn't for Mothers Against Mandatory Minimums, if it wasn't for some of you here who were engaged in advocacy in New York State, I was involved with the Isaiah Project, where Deacon Radcliffe got a number of us together and we kind of did a dog and pony show on the road. My job was to talk about addiction, treatment, and to make the point that it did indeed work. It was a viable alternative to incarceration. So advocacy, we reached new levels of advocacy due to the fact that we had to respond to unjust policy. And so the Nexus actually provides a framework deemed sufficient to synthesize all that is in this special theme issue. So now we can turn to the infectious disease syndemics of crack. Merle Singer does an excellent job of explaining the way in which these syndemics works, meaning there is a co-occurrence and interaction among not only your chemical dependency, your dependence upon crack, your crack addiction, but also there are adverse interactions with HIV, with tuberculosis, and a variety of sexually transmitted infections. And so these syndemics also involve social marginalization. They are exacerbated by factors such as poverty, trauma, and overall stress encountered in life. And so if any of you have experienced poverty for a day, then you know that there can be considerable stress in life, let alone chronic experiences of poverty, trauma, stress. And so Singer underscores how living in high-risk environments, now we're talking about that urban theme again, serve to negatively impact health and immune competence. Okay, so imagine someone who's talking about disease syndemics ends up recommending the need for structural interventions. And so in my personal work, I talk about a stress and coping bio-psychosocial environmental cultural framework. And so we're going to see that represented in this conference again and again. And this is just one example where we end up talking about structural interventions, the social structures, the conditions in which we live. We also hear in the field of health disparities and health equity talk about the redistribution of wealth, the need to basically ensure access to opportunity. And so, of course, we're talking about the social context and social determinants. And so Singer goes on to talk about policy, the need to modify laws and policies, whether addressing homelessness, whether addressing how many are reliant on the commercial exchange of sex for survival, sex workers, for those who are a part of the massive return of the incarcerated back into the community, to assist with their reintegration into the community post-incarceration, to support the family reunification process, to help them to seek economic opportunities, but also advocacy, where all of us here are very much concerned and hopefully can engage in advocacy to alter the overall economic relationships within society. And of course, if you target these factors, you're actually, as Merle Singer suggests, you're actually targeting critical factors related to mortality. And so now let's go to yet another journal article. The theme here is crack and links to HIV. And so here, this is where Bowser, Word Fullilove, Robert Fullilove, and Mindy Thompson Fullilove, who did work together at the height of the crack cocaine epidemic in California, contribute a postscript to the crack epidemic. And part of what they focus on involves sex for drugs and money exchanges, and how there are links between engaging in this kind of behavior and the crack epidemic, and of course, infection rates, especially among urban adults. And part of what they talk about, I mentioned the training of police, particularly in urban areas, to engage in stop and frisk procedures. And so the street level crack dealing may have disappeared, partly due to that intense police response. However, despite the joy of city halls who declared victories, it went underground. Crack dealing became invisible, but it did not decline from its 1990 scale from their perspective based upon their ethnographic research. And so they talk about a shift in crack dealing and how there are still those who are at risk. And they advanced a hypothesis that the unaddressed crack epidemic has served to facilitate the continued transmission of HIV, particularly in the lowest income communities. And so part of what you see at the bottom is I'm now showing how, for the work of Bowser et al., they're very much talking about that first nexus of a public health crisis of considerable magnitude and long duration. Now we can go to another theme in the journal, which has to do with impacts from sex for crack exchange, particularly for Black women and their families. And so this is where we have Sharp, who now goes by the last name LeBlanc, formerly Tanya Telfor Sharp, and the author of Behind the Eight Ball, an ethnographic study of sex for crack cocaine exchange in poor Black women. This is her opportunity to provide an update. And so basically what's focused upon in this chapter, in this journal article by LeBlanc and Wallace, involve the long-term consequences of crack addiction, particularly in relationship to prostitution, HIV/AIDS, other sexually transmitted infections, unplanned pregnancies, children who are at risk for neglect, abuse, abandonment, and also developmental delays. And so here you see that the nexus that we identify, 1, the public health crisis, 2, is nexus 5, the crisis of disruption in social progress. Imagine the progress made in terms of overcoming negative stereotypes. Yet the exchange of sex for drugs led to the denigration, in particular, of urban Black women who were caught up and, as a result of their addiction, ended up becoming involved in the exchange of sex for drugs, something that they have never thought they would do, but because of the compulsive nature of crack cocaine dependence, ended up engaging in that. So that's kind of symbolic of just, and also disrupting the relationships between men and women, and in that manner representing Nexus 5. And then Nexus 6, crisis of special vulnerable populations. And so here we're talking about not only the women who were a vulnerable population, but also their children, AIDS orphans, things of that sort. And then Frere and Wallace contribute an insider story by a medical provider, a nurse, actually a clinical research nurse at Harlem Hospital, who, as a part of her master's degree studies here at Teachers College, engaged in interviewing and qualitative analysis of her experience so that we really get a wonderful picture of what it was like to be on the front lines, in the trenches at Harlem Hospital at the height of the crack cocaine epidemic, when you had a border baby crisis. So we're talking about social welfare being called in when infants were testing positive for cocaine or crack, being immediately taken away from their parents, being left to board in the hospital. We're talking about profound stigmatization of this population so that foster care parents were afraid to interact with newborns who were infected with HIV. And so part of what we hear is this really heroic story of professionals at Harlem Hospital who provided national leadership in creating innovative models. For example, there is Dr. Janet Mitchell, who was at Harlem Hospital, who literally told her staff, go out in the community and find the woman who just missed her prenatal appointment. So we're talking about innovative kinds of outreach, for example. We're talking about a specialized clinic. We're talking about a fortuitous visit by Princess Diana when foster care parents were rejecting the opportunity to adopt or to care for HIV-infected babies. She came. Worldwide, there was a picture of her cuddling an HIV-infected baby, and within a month, the numbers willing to adopt just skyrocketed. So, and so what you see is that that part of what Frere and Wallace offer is a prescription. And so this is very much the work of the nurse, Maxine Frere, who basically, in telling her story and analyzing the data, these are the themes that emerged. What does it take to work in the trenches at the height of an epidemic when your unit is being flooded with border babies who are HIV infected? when you have to find a way, babies living in a hospital, a hospital is not a place where people are supposed to live, where babies are supposed to live for 3, 4, 5, 6, 7 years. How they ended up creating a home in the Bronx. But what emerged involved the role of professionalism, respect, knowledge, recognition of a common shared humanity. Dr. Janet Mitchell, the quote that she offered in describing the values that drove her to engage with pregnant women and to make sure that they delivered successfully and attempted to deliver drug-free, involved the notion that there but by the grace of God go I, as someone who had grown up in the projects herself and was the daughter of a domestic and a butler, who became a Harvard-educated MPH and medical doctor. Recognition of a common shared humanity, honesty, being non-judgmental, being forthright when someone relapses or when they're being non-adherent, compassion, and the most shocking variable of all, love. Okay, so I'm sure that if you were to go to a border baby unit in 1987, you might be like most people who fell in love with the babies, as well as with some of the mothers who had some success, some did not, in becoming abstinent from drugs and regaining child custody. But the theme that emerges is this, if there is a next epidemic, who do you want to care for you? And what principles do you want them to be guided by? And hopefully it involves a moral imperative, or it involves this being driven by these particular 9 factors. And so the story of Maxine Freire, we see the nexus of the public health crisis, of the crisis of special vulnerable populations, HIV-infected infants, and Maxine talks in this chapter about those who have, they didn't expect them to live. Okay, so you had grandparents who were stressed out and were surprised. Oh, this child is now living. I'm now dealing with an adolescent. Now they are having their own children. And so the focus of the clinic at Harlem Hospital has changed. So all of these special vulnerable population, AIDS orphans. And there's also innovation and evolution, because Maxine Freire was also someone who did outreach. Because when you live in the Harlem community and you work at Harlem Hospital, you see people going by. They would go back and say, oh, so-and-so just went into this particular crack house. Oh, so-and-so was on the street selling her body. We really need to get her back in the clinic, get her back on her meds. So innovation in not only models of treatment, in conducting research, models of practice, but also in outreach and advocacy, because Maxine Freire also became an AIDS activist who's been honored for her work, also created a consortium for bereavement counseling, still providing 24-hour bereavement counseling. As a matter of fact, when I needed her to approve edits to the journal article, and I was like, why hasn't she responded to my email? One of her women had died. And so she was in the emergency room and then with the family, because it becomes a 24-hour commitment to engage in this kind of advocacy and support and social action for social justice. So a crack in the life story, what is needed during drug epidemics? And so Minnie Thompson Fullilove, based on interviews for 10 years of someone who eventually died from AIDS, is able to really reveal what are the complex issues on the macro level, such as affordable housing that we've talked about, and the micro level issues, such as HIV infection. How do they operate in addictive disorder? And so Fullilove basically presents the life story, observes what's going on in active addiction, how these factors were exacerbated in terms of early childhood injury, deprivation, and then the miracle that so many of us who work in the field of chemical dependency are able to witness, and that is the profound transformation that can occur when someone emerges drug-free with an enhanced outlook on life. They begin to repair their relationships, and they can actually make powerful, profound, meaningful contributions to their community, as David Jenkins did in the context of his church, for example. And so, again, Minnie Thompson Fullilove is helping us to see how what's operating in her contribution from the nexus of 7 factors. 1, the public health crisis. From number 6, special vulnerable populations, the homeless, those with comorbid disorders of a psychiatric condition, as well as drug addiction. And again, innovation and evolution, where models of treatment evolved. And so then we can also look at the decades of evolution in community-based treatment driven by crack, so that if the epidemic dawned in 1984, and it continues to some extent, or rather the public health crisis continues, part of what I provide is a professional timeline going back to my consultation work across decades in the trenches, and outline the major developments in community-based addiction treatment, the evolution that occurred as a result of the crack epidemic. Emphasis is placed upon how the war on drugs policy created a toxic combination and indelibly marred the lives of members of vulnerable populations. So whether we're talking about infants, children, families, entire communities that experience severe devastation and trauma, if we had had a public health response to the epidemic where people receive treatment as opposed to criminal sanctions, severe stigmatization, we can only begin to imagine. I think part of what I just want to add is that, there are some of you here who have family members who became caught up in the epidemic, whose lives were transformed, housing was lost, jobs were lost, families were broken up. But there are also those of you who might have been born in 1985 who may not really realize the extent to which we are living in a social, environmental, cultural context that has very much been shaped by an epidemic. And it's as though we're living in a cage, but we fail to see the invisible structure that is surrounding us. But those who have a historical sense understand that you wouldn't necessarily have a third generation of incarceration if it were not for the crack cocaine epidemic. You might not have a third generation of family addiction. When you talk about families that are able to accumulate generational wealth, imagine those families that were poised on maintaining middle-class standing and were about to pass something on to the next generation, but they lost that $80,000 a year job that they had, and the family broke up. And so it's very difficult, and communities were devastated because of the mass incarceration crisis. So I just wanted to add that comment. But part of what we also have are a number of vulnerable populations, those separated from their parents, those who are living with, people living with HIV/AIDS, those who died of AIDS. Part of what I describe as doing some consultation work on an end-stage AIDS unit the year before the protease inhibitor Crixivan changed everything and gave us hope. And so, there was like a month in July of 1994 where there were those who were dying, and then Crixivan was given, and then there were those who, by October, were being released from the hospital. So the idea is that part of the most painful experience I had were African-American women who had exchanged sex for drugs, who were HIV positive, who died of AIDS. And what was most poignant and painful was the manner in which they had no family who came to visit them, and they had lost custody, had experienced termination of parental rights for anywhere from 2, 3, 4, 5 children. And so I was actually inspired in 1996 to write a book called Let Me Tell You Why, in the tradition of Dr. Seuss, all in poetry, all in rhyme, explaining to AIDS orphans and also to those who had parents who were HIV positive, how is it? Let me tell you why, that sexual abuse trauma made your mother vulnerable. Okay, I didn't go into all those details because it was for age 8 to 14. But basically explaining the context in which their loss and so that they could replace this feeling of abandonment with some understanding. And it actually won first prize in New York State for new HIV/AIDS training materials in 1997. But overall, looking at all of the developments from residential therapeutic community changes to models treatment tailored to women who were in inpatient detoxification or men and women in various settings, again, what applies as the framework for this work is the concept of there being a nexus where the factors that are relevant are the public health crisis, the crisis of special vulnerable populations, and of course, innovation and evolution in research, treatment, service delivery, outreach, advocacy. And then we have a voice from Canada, someone who achieved 10 years abstinence. And so again, this is someone who was homeless on the streets in Canada for a long time. And part of what she did was, she was an undergraduate in Canada writing a paper. She came across one of my journal articles and wanted to tell me how much it meant to her, especially my emphasis in my treatment articles about the need for longer, more intense treatment for those who are dependent upon crack cocaine. And so she emailed me the article, and she also emailed me a sample of her writing when she was living on the street, homeless, writing how, I don't have any underwear, and oh, there goes so-and-so walking by, and I've got this monkey on my back, and he's got a big sombrero. And the contrast was so powerful that I invited her to work on it and to contribute it. And this is someone who has gone on to engage in the work herself. She's certified in a number of areas. She has 10 years clean. And part of what she says in her article is, I've worked with the parents of addicts, and it is heartbreaking to tell them that they may have to watch their child die. I have worked with addicts themselves and urged them to believe that anything is possible. I simply do what was done for me. I tried to love them back to health by having no judgments and no agenda of my own, other than creating the emotional space or the mind shift that needs to happen to allow change to occur. And so she also says that she hopes that this letter, and all the raw truth, particularly that she provides in her writing from her active addiction, that another soul will find hope, or another person in a place of power, perhaps you, will realize their responsibility to keep an open mind and know that miracles can and do happen all the time, especially if nurtured by a system that promotes equality. So again, that takes us to our theme. And so here, what's relevant is innovation and evolution in research, treatment, models of service delivery. And then we have Kim et al., who are doing a review of outpatient treatment from 1995 to 2005, lessons from the war on drug policy. And so what do they have in their article in this special theme issue of the Journal of Equity and Health that you will be able to receive at the 5:30 reception? And so they basically acknowledge the national and global attention paid to crack, and also how it has been framed as an African-American problem. So let's go back. When I mentioned Williams, did you see a white face or a black face? Who saw a black face? Okay, who saw a white face? Okay, who still has to wake up? Well, guess what? She is a Caucasian woman. And so that's where Kim et al. Start. It's typically framed as an African-American problem. But, what about the research showing that African Americans have lower substance abuse rates compared to Caucasians? And then they go on to examine outpatient substance abuse treatment data from comparing in 1995 and also examining a 2005 data set. And so part of what they found was that the majority of African American clients had a higher percentage of being unemployed, a higher percentage reporting multiple drug use, and they were more likely to have a higher level of crack use. So again, we're talking about some disparities here, the seriousness of the issue. And so they're dealing with these particular issues. Here they're dealing with even the flawed and unjust war on drugs policy, because they end up concluding that there are lessons to be learned from the war on drugs policy for both healthcare policy and practice on a global and local scale. And then we can go to crack policy and advocacy, where some of what I talked about in my introduction is dealt with in this chapter, this journal article. And so we really analyze the social context here. And there are certain guiding principles that emerge. The importance of workers, such as yourself, in public and community health, paying attention to the policy arising in response to a public health crisis. Okay, so what happens? There's a brand new epidemic. You hear about it through the media. Something needs to be done. A proposal is made. perhaps even new legislation, as in 1986 is passed by Congress in just 30 days by people with fraudulent degrees who have contributed some of the testimony, information that turns out was just not factual, was myth and misinformation. So what are you going to do in the midst of yet another epidemic that occurs? Okay, are you going to be someone who says, well, we need to take pause? We need to look at the evidence. What does the evidence say? We need policy that reflects knowledge translation, the transfer of evidence-based or other kinds of empirical research findings, so that is what determines policy. So we end up seeing that there has been flawed and unjust war on drugs policy, the crisis of mass incarceration, the crisis of trust in the governing infrastructure, including the legislature, the judiciary, the criminal justice system, and law enforcement engaging in activities such as racial profiling, stop and frisk, the crisis of special vulnerable populations, and fortunately, at very least, innovation and evolution, such as in advocacy and policy. Then, the very last contribution to this special theme issue is on the theme of community trauma, promoting recovery through the assets-based and strength-based approach. Of course, this also includes a community-based participatory research project conducted by Howard University students with their advisor, Quimby. And the idea here is that national policy can actually aggravate social situations, which is why all of us in community health, public health, nursing, medical field, we have a responsibility. We need to know that national policy can actually erode community relations, fundamentally altering material conditions in neighborhoods, that there were those who, with a corporate governmental policy framework, were ever ready to engage in gentrification of communities that were breaking down, and this had an additional traumatic impact. And so across the nation, in urban pockets in particular, we have traumatized communities in need of social justice, healing. So Quimby basically provides a model that, as we mentioned, is a strength-based approach. And here we can see the various components, the nexus here. Of the 7, we see flawed and unjust war on drugs policy, crisis of trust in the governing infrastructure, crisis of disruption in social progress, the crisis of special vulnerable populations, innovation and evolution, fortunately, and in particular here, using community-based participatory research for Quimby. And so what does Quimby conclude? Well, he basically, through his work in this particular article, is able to share with us what community recovery can actually look like, given the work that was done in Washington, D.C., providing hope for devastated communities across the United States. And so this is what summarized the 30 years of repercussions and reverberations into the new millennium, from the dawning of the crack cocaine epidemic in 1984 to the February 2014 special theme issue, to this 30-year marking of those events throughout 2014. And so what I'd like to do is I'd like to thank you, and again, remind you that this pretty journal can be yours, and we can socialize and interact. But something very unusual has happened. I've actually left some time for questions. So we have 6 minutes for questions or comments, and of course, we wish Eric was here because Eric is the media services person with the microphone. But, oh, there goes Eric, good. So does anyone have a question? And of course, I can repeat your question loudly. You look like you have a comment or a question. No, I'm looking at you right there. You. No? Okay, you can look to the left. Look to the left, look to the right, look to the left. Yes, nice and loud. I'll repeat your question.
Thank you very much for that informative presentation.
I'm being thanked for an informative presentation.
My question is, all that background, what is happening now to advocate for the, what is the, 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 the,
Okay, given that background, what's happening now? Making what free and accessible? Well, what's happening is that people in Colorado are discovering what it's like to get high again 30, 40 years, 20 years later. They're discovering that it's a little different. But I would say that what's the purpose of all of this review? The purpose is to emphasize something called collaborative advocacy, something called evidence-based advocacy, something called knowledge translation, where we transfer information. So the lesson is that, imagine that we would have communities with intact families, potentially. We might have generational wealth being transferred from one generation to another. We might have a very different society today if we had not had the experience of unjust, unfair policy that was quickly passed through acts of Congress. And so the message is that we have to be a part of transdisciplinary partnerships and collaborations where when we witness any kind of policy that we feel is unjust or unfair, that we raise our voices. And so you perhaps have touched upon something that's very controversial. I have a colleague that I actually graduated with from the University of New York, who's head of a committee here in New York State, who has written to the governor asking that progress be made in New York State with regard to medical marijuana. So again, the research may not be there for all of the medical applications that are being attempted with various parts of cannabis, those that involve, not really using the THC component, which is associated with the high. So it's very controversial, but I would go with my colleague, Dr. Andrew Tatarski, in supporting the effort in New York State to make progress on medical marijuana. But again, it's a very different situation in various states. It's something that's controversial. Do I want to see a 13, 14-year-old have access to marijuana? No. But it's complicated. It's very complicated. Unless, of course, they have one of the medical conditions where they could benefit, then I very much would want that 13 or 14-year-old or 5 or 6-year-old or 2 or 3-year-old to have access to medical marijuana. But again, advocacy, collaborative advocacy, that's the take-home message. Okay, so I have a minute and a half. If you have there's another question or another comment. Okay, we have another question.
So the model of care that you present is incredibly transformative and long-term, and almost requires a reversal of, the policy of incarceration, which is what we found to be the solution. And I'm wondering if you compare costs, isn't that, I'm wondering what do we really need to see a reversal in the type of care that we have? Because right now it's just, whatever's cheapest and the quickest answer, and usually, incarcerating people, unfortunately, is
it clearly has been shown to be more expensive. I was on the subway listening to an African-American man who was very upset, and he was throwing around the number, it's $55,000 a year. I wanted to say, well, no, I can give you the reference where it was $28,000 per year. But that may be an old reference, I wasn't sure. So the idea is that the RAND Corporation, there have been studies since 1986 that were very clear, very persuasive, arguing for policy change. So imagine that with all of the advocacy, we're talking about collaborative advocacy that was evidence-based, that proceeded for over 2 decades. That's what it took to basically, in New York State, repeal the Rockefeller drug laws, as well as to have the Fair Sentencing Act that went into effect November 1st enacted. So let's all be very clear that alternatives to incarceration are preferable. Prison can be very traumatic, that we have in supermax prisons individuals who are being kept in isolation for up to 23 hours, who are having psychotic breaks, who are leaving prison with psychiatric conditions they had not entered with, even if you have psychological vulnerabilities, the idea that people are being returned to the community with mental disorders as well as with felonies so they cannot become employed. So we're talking about collateral consequences that are just absolutely profound. So what we